Thank you for that. A very interesting model. It really brings out this theme of consistent application across multiple interventions over a long period of time and real attention to detail as well. So we're very fortunate to have Professor Cortese with us, previous CEO and president of the Mayo Clinic, one of the US's most admired healthcare organisations, but is now Foundation Professor at Arizona State University. Is going to bring, perhaps, I think you're going to bring all of the lessons that we've learnt this morning together into one neatly defined package. Is that, or something like that?
Absolutely, that's what you asked for, and
Thank
we'll
you.
give it a try. It's a real pleasure to be here and talk with you. I'd like to set the stage. I'm going to give you some concepts that we've seen occurring in the United States as things have evolved, but I'll also go back a little bit in history to bring you up to speed. However, the topic is about integrated care and how, what does it take to get there from here? I'll also define what it is in just a minute. The fundamental, however, is it's all about leadership, as we see in the United States. It's all about leadership. Now, these are categories within leadership: shared vision, shared reality. I'll talk about those. Strategy, we just heard a little bit about strategy and some tactics, and I will cover a few of the points, not all of them, particularly in strategy. I won't go into a lot of detail because you're dealing with that, but let me take you through this concept of leadership, and I want to break it down into a couple of parts. Too many people think they are leaders because they can operate something. Operational leadership is not the same thing as organizational leadership. Quite different. And I'll try to explain what I'm talking about in that regard. First of all, what is organizational leadership's job? One of the first things is to create that shared vision. What is the shared vision? Where do you want to be? What do you want to end up with? What's your goal? I have to give you my worldview has been tainted. 40 years at Mayo Clinic, there is a quote around Mayo Clinic that goes something like this: "The best interest of the patient is the only interest to be considered." And in order to bring advancing knowledge to the benefit of the patient, a union of forces is necessary. Two concepts: focus on the patient and their best interest, and integration, union of forces. Two concepts. That's a quote from Will Mayo, 1910. At the medical school graduating class, commencement address at Rush Medical School in Chicago. That's in 1910. By 1910, the Mayo brothers had already hired their first system engineer in 1901, Henry Plummer, who was also a physician. By 1907, Henry Plummer had introduced the unified medical record for the Mayo Clinic. And it's still in place today. They began with a systematic approach of how to redesign the way care was being given with a vision in mind where they wanted to get to. They needed to take care of patients, and in 1910, when there was no medical knowledge compared to today, they were talking about that the medical knowledge was so overwhelming that no individual physician could apply it all together. That was in his speech also. Therefore, a union is necessary. A union of forces is necessary. That's the job of leadership, to set the shared vision. Where do we want to go? And then, after you do that, shared vision means, I'll define that too in a minute or two, but shared vision means every single person on your staff knows it. We have 52,000 employees at Mayo Clinic, and if you asked any employee what was the core value of Mayo Clinic, and this has been tested by many people, the janitors know the needs of the patient come first, period. That's it, it's over. So shared vision is powerful, and every single person in your organization must know it, must believe it, and it takes years to create that culture, years to create the culture. Once you have the shared vision, the next job has to occur. Show your people where they are in their performance. Shared reality. It's stunning. This works at Mayo every time. If we want to go to a certain place, We get the vision shared, then we bring in our own data, and guess what? There's always a huge gap from where we are and where we want to be. But with the right culture, if they believe in the shared vision, your culture will start moving you. They'll want to fill the gap. They'll want to fill the gap between where you want to be and where you are. Therefore, there has to be a relentless focus on your own outcomes, your own satisfaction with your employees as well as your patients, with your own understanding of your safety performances, with your own understanding, are you getting people back to work and back to school, and all of that in relationship to the costs. You have to focus on outcomes, not on process. It's the problem in the United States. That is the problem in the United States. We get paid by process. Check off the boxes, and we get paid. And when we're looking at the current results, we're finding a lot of people are complying with process. But their results haven't changed. Outcomes are no better. We're wringing our hands in the United States. Why is our safety performance not improving? You're rewarding us to do check marks when our teams already know how to get better performance, but we only get paid by the check marks. A real problem in the United States that has to be tackled. A lot of groups have changed that. So once you get those two things done as a leader, you have to then create the vision, help create it. You have to get the alignment in the staff, and you have to sell it like I'm doing right now today. I'm trying to sell some concepts to you. Okay, now, I'm going to ask you a couple of questions because you're all struggling with where you'd like to end up. Pretend every one of you is a patient, an individual. Pretend you're pre-op. Forget your job. Forget if you're a commissioner, you're a physician, or you're running an organization. Forget all that. Let me ask you a couple of questions. Where do you want to end up? Okay, here's a way to tackle it. How many people, raise your hand if you agree with this statement, how many people in this room would like to be admitted to one of your hospitals tomorrow? Put your hand up. There's one hand going up. Why? But do you want to be in the hospital tomorrow? That's a different question. I'll get to that. Do you want to go to the hospital tomorrow? No. Who would like to be sick tomorrow, which is his question? Put your hand up who would like to be sick tomorrow. Third question, who would like to be a patient? Patient defined by the dictionary as somebody who long suffers and long endures. Put your hand right up there for that. Who wants that? Now, we're all going to have conditions. I got 5 major medical problems, but I have to live with them. And I prefer to only go in the hospital once rather than 22 times. So I'm not saying we're not going to go in the hospital. Of course I'm sick. I want to go to the best hospital. But the vision is you don't want to go to the hospital if it could be avoided. You don't want to be sick if it can be avoided. And you prefer not to be a patient. Yes, you may have conditions, but you want to function. You want to be a person. You've just done the strategic planning for your healthcare system. You're through. How are you going to get there from here? One way to get there from here, and I'm just going to give you a few examples of what we actually focus. This is our strategic thinking at Mayo Clinic, but it also represents many, many other organizations, not the whole delivery system in the United States, but several hundred of the best organizations have these same concepts. They may not use these words, but they have the same concepts. First of all, they are a learning organization, which means, very simple, everybody in the organization knows what the organization knows. And most of them know it within a click of a button on the computer. Patients, too. That's a whole task to get that. But assuming that that's where we're going to build upon, what do we want to build the learning organization for? What's the purpose? Here's the purpose. The sole purpose that we should be existing is for value. Value in healthcare, very clearly defined. It's the quality compared to the cost. We all have to make a decision to buy one of these. Most of you do. You all make a quality decision and a cost decision. You are buying value. I have a BlackBerry because the most important thing to me in my numerator, in my quality component, is the ability to do a lot of texting and messaging. I like the keypad. I could care less about the apps. But that's important to me, and I'll pay the cost. It's a quality decision we all make every single day, and therefore we have to define what are the elements of quality. In healthcare, the elements of quality should be the outcomes that you're expecting, and that can be condition-specific. Many people in the U.S. say we can't measure quality. They've been saying that for years, but after all my time at the Institute of Medicine working on this, you can measure quality, just define it. And let the physicians be engaged, let the patients be engaged. Total hip operations, do we expect the hip to fall apart in 2 days? Do you expect to have an infection? Do you expect not to get out of bed the same day that the hip operation is done? Liver transplants, do you expect to be in the hospital more than 4 days? Do you expect to go into an ICU after a liver transplant? The answer is no. How do I know? Because the best organizations in the country, no stop in the ICU, up out of bed after the liver transplant and home in 4 days. That's the standard. That's how you measure outcomes. The standard becomes the best performing organization. Therefore, you have to have a relentless focus on measuring outcomes. And you define them by whatever condition you want. Let's take asthma kids in Phoenix, Arizona. We have a project going on right now for children under age 15 who are on welfare, on Medicare, Medicaid. The question is, how well are we doing treating asthma patients? The measurements are, how many days in school are they missing? The average is 40. How many kids go into the emergency room? How many kids get admitted to the hospital? Can we design new ways to care for each one of those patients so we get their days lost of school to 0? Pretty easy. Not easy to get done, but easy to measure. So it can be done. So value is the primary focus, and value is outcome, safety, service, productivity, being in school. In the United States military, the equation they use, I work with them, the equation they use in the numerator is readiness. Can they fight? Measurable. The generals know who is ready to fight every day on their computer. And then the denominator is cost. So value is your quality compared to the cost. It's that relationship. To get high quality, when we've studied this through the Mayo Clinic Health Policy Center, we had 4,000 people nationally work on this for 5 years. It turns out, by happenstance, that organizations that have been integrated and providing coordinated care for the last 50 years, before we ever talked about those things, a byproduct is higher value care. They didn't sit down 50 years ago and say, let's make higher value care. They just felt integrating the care and coordinating the care paid off. Integration is defined as all the providers working together. Coordinating the care is defined as how you give the care to the patient wherever they are in the world. Whether they're at home, school, work, or in your institution, getting care. So integrated and coordinated care becomes a fundamental base that we have to be able to generate value. You can't get there without it. There's a couple of pillars. Individualized medicine. To improve the health of a single population, whatever group of people you want, you must individually design the care that's needed for each individual. And I think I've got to mention that. Individualized care, it should be focused on the patient, and you may have to orchestrate the way you care for that patient based on their individual needs. And if you don't look at the population and dissect out the individuals, you will not improve the health of that population. You can get a wonderful pathway and apply it to that whole population, and you'll fix 80% of the patients, but you're going to miss the other 20, and you'll never improve without understanding that the other 20 are different. Different needs, different social problems, different desires, home circumstances. You have to get into the home to understand what's going on, or into the school. To do all of that, you need to have a concept of the science of healthcare delivery. This is not basic research. This is applied research, system engineering, process management, lean management, system flow, being willing to experiment with models of care. And it also means you learn from other organizations. And I can tell you with 100% certainty that the processes that Harvard uses to take care of certain patients do not work in Mayo Clinic. Reproducing their processes of a great organization doesn't mean you're going to get good results. And our people in Washington and our regulators still do not understand that. If they find a good model, heaven forbid our regulators find a good model, they'll come out and say everybody has to do it this way. What they should be saying is, here's a good model, look at their results. Everybody should get those results. We don't care how you get there. Now, there's a tremendous purpose to process. Don't misunderstand me. Process is absolutely important, internal to the way you do business, so you can change it and improve it. But reproducing the process from one organization to another may work, but most of the time it doesn't. If they're like on our liver transplantation activities, our lung transplantation activities, there are 75 process steps that we've dissected. When we studied other organizations, because we weren't doing as well as we should have been doing, we found 9 process steps that we modified. And within 2 years, we were right at the top. Because we already understood our process, but we learned from other people they were getting better results. We came back, modified our processes, and improved. That's what I mean by a learning organization, system design, science of healthcare delivery. In the United States, there are 2 other elements that we have to have. I can't say if it's the same or also true for your country, but one of which is, if we want high-value care, we ought to pay for it. If we're going to pay still fee-for-service, which means, at least in the United States, I make money when you're sick. How are you going to get there from here? If I keep you healthy and out of the hospital, I go out of business. So we have to totally change the way we're providing care, and the way we have the models of care, of payment have to change too. That's underway in the United States. And then insurance for all. This is an issue in the US. You already have that one pretty well handled. We are working on that now. Slowly and trying to get there, but we will get there. Okay, so I'll go quickly through the rest, because these are just now some key points. If you agree with the idea we need to have a clear vision and we have to have a shared reality, and some of those elements are coming into place that we just talked about, here's a little tip. The two rules that I follow quite often. You have to communicate to the staff. You have to go to the trenches. You have to visit with them and talk with them. The leader has to do it personally, not a substitute, not somebody else. The leader has to do it. And you have to say the exact same thing to the same people 8 different times, minimum. The first time, they're going to say, what the heck's he talking about? Second or third time, this is really dumb. This is not what we're interested in. 4th or 5th time, they say, oh, Cortese's out there doing it again. 6th or 7th time, they say, what's he talking to us for? We kind of know this. The 8th time, they say, what are you even talking to us? We know all this. This was our idea. It pays off. Because that's when you've got the shared vision, is when they start seeing it. Second point is, you must have the rule of the square root of n. This is an engineering rule. If you want to start changing your organization, you've got to get to the square root of your organization. You have to get At Mayo Clinic, we had 52,000 employees. I chose to start with physicians back in 2002 when we really changed a lot of things we were doing. Took a square root of that. We took 250 physicians that I actually identified by name, by purpose, and I picked the toughest ones I could find. Department chairs and leaders, et cetera, but also the boat rockers. The people who didn't agree with change. Made sure they were in the room and they had to come 8 different times to talk about the exact same thing. The square root of N helps you really move the organization, because once those people, your naysayers become your leaders, by the way. The naysayers start coming along, they become the leader, because all the others say, hey, something really here is going on. It makes a big difference to get things moving. So the rule of 8 and the square root of N really helps a lot. Now, let's shift to operational leadership. I will not go into a lot of detail because all of you are living with this every day because it's the default. Most of us have to do operations all the time, and we get blinded from the organizational stuff we have to do because we're so entrenched. We have to deal with strategy, tactics, but that requires planning, organizing, and most importantly, measuring. You have to have your data and you have to have your measurements in place as you go forward. I won't go over strategy and tactics. You're all probably experts at that. But without a shared vision, those strategies and tactics aren't going to work. As a matter of fact, a very good example, D-Day, the 70th anniversary is coming up soon. And I'll be coming back again to go through all of it because I'm a real fan of understanding the decision processes that went. Let's just take D-Day. Soon as the troops all started to land, British, the Canadians, the Americans, when they started to land, nothing went on plan. Nothing went on plan. The 101st over on the west side, trying to get to Carrollton, they were spread out all over the place. Omaha Beach, complete confusion, no plans. And look at the Pegasus Bridge when the Brits landed. As soon as those gliders came in 10 yards away from the bridge, nothing went on plan afterwards. However, they were all successful. Why? Because they all knew the goal. Having known the goal, all of a sudden they said, our plans aren't going to work, so they self-organized right on the spot because they knew what they needed to accomplish. The shared vision was there. It was powerful. And they self-organized and they did what they had to do. Okay, ACOs. ACOs in the United States are an official term by the federal government, but basically what it is are organizations. Organizations are folks that have come together, physicians, nurses, frequently hospitals. Sometimes they already own their own insurance company. So that could be the organization. And they've agreed to focus on a population of patients, and they're going to be accountable for the value that they're producing, their results compared to the cost over time. But to do that, they need a business model that's viable. So these are the 3 major components. You're already focusing on those. Your population, how do we create value and how do we measure it? And then a business model that you can stay in business. You can stay in business. My definition of staying in business, by the way, is very clear. Get your costs covered and a 2 to 4% margin. You cannot stay in business with a 0 margin. Not in the US. Maybe you can do it in England, I don't know. But not in the US. You need a little margin. And people have to understand that. Because you can't grow, you can't change, you can't modify. Let's talk about business models, because they may be applicable to you at this point. First, payment models are important to consider. What is the payment model that might work for you? Fee-for-service might work. I'm not convinced of that, but it could be, and I'll show you in the next bullet point, I'll mention where it could work. Extended DRGs. Extended DRGs mean you are responsible for the cost and the care of the patients after they leave the hospital for a length of time. 30 days, 60 days, 90 days. In liver transplants, we use a big extended DRG, which you would call a bundled payment. And on liver transplants, all our capitations are done within a year, 2.5 years. The longer we go, the better we do. Because if you are bundled for that patient that whole time, every incentive is in line for you to keep that patient healthy. Because if they come back and you have to redo the transplant, you're going to lose money. There's no more money on the table after you take a bundled payment. And the results are spectacular in the US with regard to transplants. And then, of course, capitation. So those might be business models to think about, but then how do you apply them to what you're actually producing? What are your products? One product to think about, Clay Christensen's concepts. Number one is the solution shop. Solution shop product is the thing you have to do for patients who are very ill, very sick, have an undiagnosable or very difficult condition, or multiple problems that need to be tuned up, fine-tuned. You may need to bring a solution shop, which is a group of experts that would come together to try to coordinate and integrate everything around that patient to simplify that care and make it real clear. That may require fee-for-service, because you're not really clear what services you need early on to get that patient's plan accomplished. I can also see doing it under a bundled payment too if you get really good at it. Like Mayo Clinic could do solution shop work in a bundled payment. But when you do solution shop work, maybe fee-for-service does work. And the solution shop will only be 10 to 15% of your practice. It's not going to be everybody by a long shot. But then when you get to the other side, the value-added process business, that is what Clay Christensen means by, now you've made a diagnosis, now you made the plan, now you're going to do something. Like you're now decided we're going to do a hip operation. From then on, diagnosis is made, it's all process. And you have to do everything you can to get the process exactly right. Is the care correct? Is it timely? Are you avoiding complications? Is it being done safely, etc.? That's a system engineering design problem. That can be bundled payment or capitation, however you want to look at it. And then the third is virtual care. How are you going to get paid when you take care of people at a distance using laptops and computers and cell phones and things like that? In the US, there's a big push to try to make that fee-for-service. Just like everything in the US has tried to be done fee-for-service, it's probably not the right way to go. Once you're involved with the population, I would submit you probably ought to do this for free because it's part of your bundle. It's part of your capitation. If you can take care of the patient, keep the kids in school, keep the people at work, and they're not seeing you in your office, that fits with your strategy. Keep them out of the hospital, keep them out of the office. Then finally, I'll finish with this. This is the last point, prevention models. In the US, everybody says, well, what about prevention? Most people in the US do not know what they mean by prevention, because there isn't such a thing as just prevention. There are several kinds of prevention. Let's take a look at this. These are some options for strategic thinking or tactical thinking. Here's your population that you're stuck with. You've agreed to take care of them. It may be all the people in your own insurance company, like Kaiser does, Intermountain, Scott White Clinic, Geisinger. There's many clinics in the United States that have their own insurance plans. And that population is their risk. Top to bottom, that's all the money they get. Or you could make a contract with an employer, and you're taking care of all their employees. It could be your own employees yourself in your own hospital. However you define the population. It could be all the people with asthma in your community. Once you define the population, you will find quickly that in that total population, there are a subgroup of patients who really are at risk for an illness or developing a chronic condition. And you may have tools to predict that risk. The more we start looking at genetics and genomics and proteomics, we may be able to predict that even better. I don't know. That hasn't met our expectations so far. But clearly, there are people, smokers and things like this, you know are at risk to get a condition, but they're healthy otherwise. They're not even seeing you. They're just functioning. Then there's another group of people who have a chronic condition already. They have atrial fibrillation, they have congestive heart failure, they have diabetes. And then there's a third group who are acutely ill. They may be acutely ill from their condition. When I mean acutely ill, they may be in the hospital or they may be in your office with uncontrolled asthma, uncontrolled diabetes, but they're acutely ill related to their condition. All right, now, when you look at those, the acute illness patients are the ones that are going to cost a fair bit of money. The chronic illness patients are going to cost a fair bit of money. So when we start talking now about prevention, what can we do with regard to prevention in that whole population? If you tactically take it by segments, primary prevention is what we do to try to keep people from becoming at risk for a condition. Primary prevention would be like giving people a vaccine, for instance. It costs money to do primary prevention, and the return comes later. Good return for some conditions, but the return may come 30, 40 years later. Another level of prevention is secondary prevention, and that's those people who have the chronic illness, who are at risk for the chronic illness, obese people that you expect to get degenerative arthritis, you expect to get high blood pressure, expect to get diabetes. How do you prevent them from falling into the chronic disease category? That's secondary prevention. That costs money. You have to spend money to get it, to do that, but your return would probably be shorter than 40 years. It might be 5, 10 years. I don't know how long it would be. Depends on the condition. Next level is people with chronic condition who go into the hospital a lot or into your office a lot. How do you keep them living with their chronic condition and functioning well so they don't go in the hospital and don't come into your office as often as they were doing before? That's tertiary prevention. And then finally, there's quaternary prevention, which is those people who are acutely ill. Quaternary prevention has two components. One, when they're ill, what you do to them should be done the right way the first time. Avoid complications. It's what we do in the hospital when we do system design. The other is that we don't overutilize tests and things for them. We don't do more than they actually need. Now, the reason I'm breaking that apart is because most of the money in healthcare is spent at chronic conditions and the acute illnesses. Way, 80% or more of the dollars are spent, at least in the United States. And we are working a lot on quaternary prevention, but there's a lot that can be done with tertiary prevention. Keep people healthy and active with their chronic condition. Those steps save you money right away. So if you are a CEO of an organization, you say strategically, since I have no more money to spend, where am I going to get the money to do this whole population management? You're going to get it right at the bottom. So when you begin the process of the accountable care process, if you can begin focusing on the sickest patients, you'll have a bigger return, and you really begin at the bottom and you work your way back up. As you're freeing up money, as long as the money stays in your system, you can then apply what you save in quaternary care, you apply into more tertiary care. Tertiary prevention, how to keep people functioning and out of the offices. And when you start saving some money there, then you're moving up to secondary prevention and doing a lot more primary prevention. Because so many people in the United States keep saying, we need to do primary prevention, and the next thing you say, well, you ask them, how are you going to do it? And they say, well, we need to have more money. There is no more money. So you have to function as an organizational leader to say, given there's no more money, how do I tactically accomplish this? So I'll stop there and thank everybody for listening and leave it at that. Thanks.
Thank you.